Hi, Dr. Raj here, and I want to do something very timely. Unfortunately, with all this COVID-19 pandemic, it's time to talk about some of the worst cases out there. I wanted to talk about ARDS and ventilator management. Many individuals ask me, well, how do you die from COVID-19? And you could definitely get a pneumonia by itself. You could get a secondary pneumonia from being predisposed and immunosuppressed from the virus itself. And some individuals can develop something called ARDS. And what is the ARDS? It's adult respiratory distress syndrome. And by having ARDS, you have to be placed on a ventilator. And this is why questions always come about. Do we have enough ventilators? Do we have enough ICU beds? So I feel that this is going to be very timely. So I think that I wanted to start this off with a case. And then from the case, we'll go ahead and talk about some of the high yield things when we talk about managing ARDS in itself. So we have a 63-year-old woman. Stop right there. Is anyone surprised that when we're talking about ARDS and COVID-19 that the individual is going to be older in age? The answer is no. One thing that we do know is that people who are older in age are more predisposed to having the severe consequences of COVID-19. This is contrary to when we think about influenza. Influenza virus is still very horrible, but we think more about younger adults and kids getting influenza. But when it comes to COVID-19, definitely older in age, we worry about. So this 63-year-old female does have COVID-19. And, how do we know that? This leads to diagnosis, meaning that we do a nasal pharyngeal swab and we do a PCR. So she was diagnosed with COVID-19 and she's admitted to the hospital for septic shock. Secondary to what? Community-acquired pneumonia, which kind of goes into what I say. How do you die from COVID-19? Once again, most people are going to be what? Minimal symptoms, asymptomatic, upper respiratory tract symptoms. Only a small portion are going to go on to develop septic shock and, respiratory failure. But in this case, patient had a secondary infection from a community-acquired pneumonia. So my question is, well, what is the classic bug that gives you a community-acquired pneumonia? The answer is strep pneumoniae. So common things are still very common. So probably had a strep pneumoniae secondary infection. And when you have infection, you're always predisposed to developing what? Sepsis and septic shock. And it sounds like she has septic shock. And how do you define septic shock? Everyone, elevated lactic acid, blood pressure, meaning the mean arterial pressure is less than 65 after fluid resuscitation. This is not looking well for this 63-year-old female. So after receiving hydroxychloroquine, antibiotics, which include azithromycin, stop right there. That when we talk about COVID-19 and we talk about the treatment, the answer is there are no FDA-approved treatments when it comes to COVID-19. There aren't. But what is the hottest topic right now is using this antimalarial called hydroxychloroquine. Many people may also know this medication when we think about patients with lupus, with rheumatoid arthritis, with sarcoidosis. So this combined with azithromycin, and why did she get azithromycin in this case? She was worried, they were worried about what? Community-acquired pneumonia. They probably got the combination of ceftriaxone, which is a third-generation cephalosporin, as well as azithromycin because they're covering for what? Atypical bacteria. And it's this combination of hydroxychloroquine and azithromycin that's receiving all this press. Stop right there. If you wanted to hear me discuss the study that's raising all this attention and controversy, please, I just made a video literally 5 minutes before doing this that really dives into it. It's going to be out on my social media and websites. Please take a look to hear the details about this. Back to the case. Fluids were given, pressors were given, probably Levophed, which is norepinephrine, and things like vasopressin, and her condition stabilizes. However, subsequently, she develops ARDS and is intubated. So what a surprise, when we talk about ARDS, we don't manage these with BiPAP or CPAP or high-flow nasal cannula. And that's not surprising, especially when we talk about COVID-19. There's data out there to show that you may further aerosolize the virus by using BiPAP, CPAP, and this high flow, which means that if you have patients with COVID-19, they are in respiratory distress, you don't have many options but to put them on the ventilator safely. And that's why Many hospitals have what's called a COVID team that directly manages the airway in a very timely and safe fashion so we don't expose everyone to the virus itself. So anything can cause ARDS. We'll talk about that, but especially when you ask me the question, how am I dying from COVID-19? It's the subsequent secondary infections and people who go on to develop ARDS. So her oxygen requirements increase until she is receiving 100% oxygen. The ventilator settings are in this volume-controlled, continuous mandatory ventilation mode with a respiratory rate of 22, a tidal volume of 330, which is around 6 mLs per kilogram of ideal body weight. Her FiO2, how much oxygen I'm giving her, is 100%, what a surprise. And her PEEP, which is positive end expiratory pressure, is 5. So we check a peak and plateau pressures. The values are 25 and 22 centimeters of water respectively. So we examine our patient. On exam, the patient is febrile or low-grade fevers, which is not surprising. When we talk about COVID-19, many individuals have fevers. I'm sure when you want to walk inside your hospital, they're always checking to see if you have fevers, and this patient does. Normotensive, the patient's heart rate's elevated at 105, respiratory rate of 15, the skin is cool, there's no JVD, the heart sounds are rapid and regular, but otherwise unremarkable, and diffuse crackles are heard on pulmonary exam. There is no edema. And why am I mentioning all these things is because you want to rule out heart failure when we talk about ARDS. Can COVID-19 give you heart failure? Well, the answer is yeah. And that's one of the hot topics now is, can COVID-19 induce a viral cardiomyopathy? Any virus can do it. And of course, why not COVID-19? But in this particular case, the physical exam, points more towards a primary pulmonary issue rather than a secondary heart failure issue. And the remainder of the exam is non-contributory. We do an arterial blood gas that has a pH of 7.31, a CO2 that's elevated at 50, and a PaO2 of 54, which is extremely low. Patients hypoxic and hypoxemic. They do a chest x-ray that shows extensive patchy areas of opacification of the lungs. And to mention, there is no classic x-ray or imaging finding for that matter that diagnoses COVID-19. If you want to make the diagnosis, once again, you need to have that nasal swab. You need to look for that, do that PCR, looking for that viral load. So when we talk about some of the questions that clinicians in the ICU need to make when it comes to managing patients with ARDS, it's the following. Should I decrease the tidal volume? Should I implement a prone position maneuver? Patients hypoxic, should I give inhaled nitric oxide through the tubing or some prostacyclin analogs? Should I decrease the respiratory rate or increase the positive end expiratory pressure? Or should I do something called venous ECMO, extracorporeal membrane oxygenation? It is invasive. We will talk about it. When we talked about the last flu epidemic, patients who had severe pulmonary complications from the flu, they've used ECMO with success. So I'm not saying that is the next step, but are these things that we should talk about, and what is the correct answer? So before we jump into this, I want to talk about ARDS. I do want to talk about ARDS, and maybe we'll go back and we'll answer this question. So when we talk about adult respiratory distress syndrome, well, how do we define it? There are two definitions. One will be the classic definition I wanted to mention, which is the one from 1994, and it was based upon three main things. It was a syndrome. So what are parts of the syndrome? Number one, a PF ratio. What does the P stand for? A P little AO2, partial pressure of arterial oxygen, divided by your fractional percent of inspired oxygen, the FiO2. So if I were to do an arterial blood gas on myself, my P little AO2 would be around 100. I'm breathing 21% oxygen. So if I take the 100 divided by 0.2, the number should be 500. But as you become more hypoxic, the P little AO2 will go down. You'll probably end up giving more oxygen. The FiO2 will go up. So what happens to that number? It becomes lower and lower and lower. And in the old definition, a PF ratio less than 200 defined ARDS. You also needed to have acute bilateral pulmonary findings. And the last thing was something called a PCWP, a pulmonary capillary wedge pressure. And as you can see from my diagram here, this is something you measure by performing a Swan-Ganz catheter. Over here, you see that the balloon is wedged right here in the pulmonary capillaries, and it measures things distal to the wedge. So it was a marker, an indirect marker of left ventricular end diastolic volume. Many of you refer to that as preload. And if you have heart failure, you can imagine that you would have an elevated Swan reading. So having a pulmonary capillary wedge pressure less than 18 tells you that it's not the heart, because what mimics ARDS on imaging? It could be things such as heart failure. So what causes ARDS? Well, direct causes are going to be aspirations. Unfortunately, many people aspirate. Pneumonias, and this is where COVID-19 will take place. When you get that direct damage to the lung itself, you can get ARDS, not to mention these secondary pneumonias. Or you can get indirect causes. And the one I wanted to focus on the most is sepsis. And of course, that's what we worry about in the patients who come in with COVID-19, and it sets off this cascade of inflammation in the body. All of a sudden, your blood pressure is dropping, you develop sepsis. So in this patient that we just talked about, there was direct damage to the lung, patient was septic, had many reasons to have ARDS. But regardless if we call them direct or indirect causes, we treat them both the same clinically, physiologically, and their management doesn't differ, but of course you want to treat the underlying cause. And in the case of COVID-19, that's why many of us are crossing our fingers to hope that this hydroxychloroquine and azithromycin will be a positive finding soon when it comes to management of these patients. So as I mentioned, there is an updated version, meaning definition of ARDS. It's the Berlin definition. And I don't want to spend a lot of time on this, but what are some key parts of this definition is that the respiratory symptoms of ARDS must happen within 1 week of the known clinical insult. In this case, patient was diagnosed with COVID-19. Another part is that PF ratio will let me know if it's mild, moderate, or severe ARDS. Mild ARDS is going to have a PF ratio between 300 and 200, moderate 100 to 200, and less than 100 is severe ARDS. But one important part of this definition is that these patients need to be on a PEEP, positive end expiratory pressure, of greater than 5 in order to meet this criteria. And when it comes to doing a Swan-Ganz catheter, like in the old definition, the answer is no. We must rule out cardiac etiologies maybe through clinical or non-invasive ways, such as maybe getting a transthoracic echocardiogram or checking labs such as a brain natriuretic peptide. But you don't need to do a Swan-Ganz catheter. So what is ARDS? I put a wonderful picture up here, and the way I summarize it is like, look at my hand. It's almost like one balloon. This balloon is going to represent an alveoli, which is what you see on the screen. So what happens to ARDS? The alveoli is going to shrink. And when it shrinks, it also gets filled with this inflammatory exudate right here. So you can imagine on this side of the diagram, this is a wonderful, beautiful alveoli. Our lungs contain millions of alveoli. And when you have ARDS, some of these alveoli will shrivel up. Look how it's smaller than the regular alveoli and filled with this inflammatory fluid. So the question becomes, where does inflammatory fluid come from? And we'll talk about that. But there is no prophylaxis for ARDS. What is the lag time? Definitely, it's going to happen within the week, usually around 24 to 72 hours from the initial insult, such as our patient in this vignette who had COVID-19. So when we talk about ARDS, what are the hallmarks of adult respiratory distress syndrome? Number one, they're going to be hypoxic. They're going to be hypoxemic. That's why the patient's on 100% oxygen. It's difficult to oxygenate these patients. And they're going to have diffuse bilateral chest x-ray and CT findings. And I'll show you some examples of that. We do not go around biopsying individuals with ARDS, but if we did, what is the pathological hallmark? There's something called diffuse alveolar damage. And when you look at this sample I gave here, it's showing hyaline membranes. which is one of the key histological features when we talk about diffuse alveolar damage. So remember I said that the alveoli are going to be filled with this inflammatory fluid. Where did it come from? So I wanted to go back to a little physiology. Up here, this is what we call Starling's forces, where we talk about hydrostatic and oncotic pressures. So when we talk about hydrostatic pressure, it's a force that pushes things out of the vessel. And when we talk about oncotic pressure, this is going to be the force that things such as proteins exert. And think of proteins like little sponges that suck fluid into it. So if you look down here, here's a pulmonary capillary in blue. This red biconcave disc is your favorite red blood cell. And all these brown circles are proteins. So what happens with heart failure is that you can imagine the left side of the heart, the left ventricle is not working. All the pressure backs up, and therefore fluid will sequester out of the capillaries and go into the alveoli. But that's not ARDS. In ARDS, what happens is the pulmonary capillaries become very friable, meaning that these proteins could leak out of the pulmonary capillaries and they go into this area called interstitium. And what do? These proteins are like sponges. They suck up all the fluid, so the fluid will go into this interstitium and also go into the alveoli, leaving your alveoli shrunken up and filled with fluid. So you can imagine you cannot have gas exchange going from your alveoli into your bloodstream. That's why you're hypoxic and hypoxemic. So here is a chest x-ray. If someone comes in, it looks like they have a right lower lobe opacification and density. And most of the time when I think of a right lower lobe density, what causes that? Aspiration. And what happens around maybe 48, 72 hours later? This on the right. And when you look at this chest x-ray, I mean, what type of disease is ARDS? Is it a homogeneous lung disease or a heterogeneous lung disease? And the answer is heterogeneous, meaning that there is going to be some good lung, there is some bad lung, otherwise known as good alveoli, bad alveoli, and you can tell on this chest x-ray, these areas could be a little better aerated than these areas over here. So that's going to be very important to realize it's a heterogeneous lung disease, because what alveoli, what lung are we trying to save? It's not the bad lung. The bad lung's done already. It's the good lung. We want to preserve that. And we'll talk about how we do that on the ventilator. Another thing I wanted to point out is that this patient is intubated. And anytime someone says the words ARDS, they're only managed on the ventilator. And once again, when we talk about COVID-19, we don't use high flow, we don't use CPAP and BiPAP because we could spread the virus. So unfortunately, if they're in respiratory distress and have COVID-19, you want to safely intubate them in a timely fashion. So this is a chest x-ray with no history, no physical. And I wanted you to realize that if someone were to ask you, is this ARDS? The answer is, I don't know, because you don't know the PF ratio. You don't know what PEEP they're going to be on. You don't know the findings of the left side of the heart. You don't know if these are acute or chronic. So this could be in the right setting, someone with miliary TB. This could be someone with PCP pneumonia, someone with heart failure, or someone with COVID-19. And that's why you do need the history and physical to figure out exactly what may possibly be the cause of this individual possibly developing ARDS. So when we talk about some treatment considerations, like I mentioned earlier, you always want to treat the underlying cause. The most common thing is sepsis, so we want to give the right antimicrobials. In COVID-19, cross your fingers, hydroxychloroquine and azithromycin, maybe. We want to optimize cardiopulmonary support. What do I mean? When patients go on the ventilator, their blood pressure drops based upon physiology. Not to mention they'll be on sedatives that will drop your blood pressure. Not to mention they're on sepsis. They have sepsis to begin with. So giving them appropriate fluid resuscitation and using what we call pressors to maintain cardiac output and blood pressure support is very important. We need to feed our patients when they're on the ventilator. And as far as medications for ARDS itself, there is still a role for steroids. This is not the same for COVID-19. If you have COVID-19 by itself, you would not give steroids, But if someone has COVID-19 and ARDS, well, then a judgment call is, do you need the steroids to treat the ARDS? So what are the data for steroids specifically for ARDS? Well, New England Journal of Medicine in 2006, they gave some steroids, more than some, but they gave it 2 weeks after the onset of ARDS, and it could increase the risk of death. So people stopped giving steroids. Then in chest in 2007, they gave steroids earlier in the course, and it showed that, hey, the duration of mechanical ventilation was reduced, and ICU length of stay was also reduced. So then again, steroids came back into favor. And for those of you who practice critical care medicine, you know critical care medicine is a pendulum. So all my answers depend on what year did you ask me the question. So it depends. But the take-home message from these two previous trials was that if you're going to give steroids, you want to give them earlier in the course. Why? It's because ARDS has different stages of disease. The earlier stages are called the exudative stages, which is very inflammatory, and that's where steroids will really get the big benefit. These will progress to a proliferative stage, and at the end, to a fibrotic stage. So by giving things like steroids in the fibrotic stage, you'll probably get all the downside of steroids and not the benefits. So when we talk about ARDS, the big thing now is how do we manage them on a ventilator? This is why we're so worried about having enough critical care physicians available to treat patients with COVID-19. Do we have enough ventilators? Do we have enough ICU beds? And the key thing is that if you have ARDS, this is what we call shunt physiology, meaning that the big problem is with getting oxygen through the alveoli into the capillaries. So the big thing is not going to be the perfusion of oxygen. The big thing is having oxygen diffuse through the lungs. It's a shunt problem. And the way that we reduce mortality with patients with ARDS on the ventilator, the way that we improve survival is by giving low tidal volumes. And I can't say that enough. And we use somewhere between, 6 mLs per kilogram of body weight, which is, very low. We slowly titrate down towards that, but we use low tidal volumes. Why? Is because when you have ARDS, once again, there's good alveoli, there's bad alveoli. If you give big tidal volumes, all that airflow will go to the good alveoli, and what's going to happen? Poof, rupture, barotrauma, volume trauma. So we give low tidal volumes so we could protect the good lung, the good alveoli. But are there going to be some physiological consequences of giving low tidal volumes? The answer is yes. One of the main things that's going to happen is that your carbon dioxide is going to go what? Up. When we call that permissive hypercapnia. The patient's carbon dioxide went up because you gave low tidal volumes. Why? Because it improves survival, but these are one of the consequences. So back to my question in the beginning, notice that the patient had a respiratory acidosis with a CO2 that was elevated around 50 and a pH that was low around what, 7.31? That was appropriate based upon the patient getting low tidal volumes. So I would not manipulate this patient's tidal volume any lower, or I wouldn't increase it, and I wouldn't change the respiratory rate, because the two things that affect the CO2 in the blood is going to be your tidal volume and respiratory rate. If you multiply those two together, it's called your minute ventilation. And one of the things I put on the bottom is positioning. And because ARDS is about good lung and bad lung, they're both are going to be involved. Sometimes if you put the good lung down, you will get better blood flow based upon gravity and get better VQ matching. So you'll see that clinically from my ICU doctors that maybe for a time being, put the patient left side down or right side down based upon the chest x-ray findings. But this is only for a bridge to help out with oxygenation until you could find more definitive ways to treat the ARDS. And notice I put a little New England Journal of Medicine article right here. When we talk about ARDS on the ventilator, we do want to use a conservative fluid management. Once again, in the beginning, when you're septic, when your blood pressure is low, fluids, fluids, fluids. But once things are going in the right direction, you want to use a conservative fluid management because it helps out in trying to get them off the ventilator in a timely fashion. So let me do one physiological question. A patient with ARDS is on the ventilator with the settings of 12 mLs per kilogram of the patient's tidal volume. this was switched appropriately to an ARDS net protocol, and that's where a lot of the data comes from. It's the ARDS net studies, and to 6 mLs per kilogram to improve the patient's survival. What physiological changes would you expect? And look at all the different choices there. Is compliance going up, going down? Is oxygenation going to improve, or it's going to get worse when you do going from big tidal volumes and cutting it in half to small tidal volumes? And not to steal everyone's thunder away, the answer is going to be, if you have an alveoli and I cut your tidal volumes in half, what's going to happen to the alveoli? It's going to what? It's going to shrink. And what is the medical word when your alveoli are collapsing? Atelectasis. And when you have atelectasis, is your lungs going to be more compliant or less compliant? That's right, less compliant. And because you have atelectasis, what happens to surface area? It decreases. So what happens to oxygenation? It's going to decrease. So by doing the things that improve survival, the low tidal volumes, what happens to compliance? It decreases. What happens to oxygenation? It gets worse. What happens to your CO2 level? It goes up. All these things are worrying me. But even though the answer is B, the question becomes, do I want my patients to have non-compliant lungs that are hypoxic? The answer is no. So what can I give my patients on the ventilator to help balance out the effects of the low tidal volumes? The answer is PEEP, positive end expiratory pressure. And answer is B. And I love this diagram because it shows that when you want to have good ventilation, that it's somewhere between points B and C. Point A is an alveoli that's very, very collapsed over here, very non-compliant. And point D is an alveoli that's over-distended, ready to what? Pump. But the sweet spot is somewhere here between B and C. And that's why when you talk about ARDS, it's a balance between low tidal volumes and PEEP. So you could be here right in this sweet spot. So when we talk about advanced ARDS, it's unfortunate that many of my patients with COVID-19 who develop ARDS will probably need some of these. So let's kind of go over this briefly. I mentioned earlier about ECMO. That was one of the choices. That wasn't the correct choice for the question. But, you know, ECMO it's called extracorporeal membrane oxygenation. It's kind of like dialysis of the lung, you know? So it's a machine, and you need to actually team up with your cardiothoracic surgeons. You need to put in these big catheters in the patient. And there's two broad types: venous ECMO, which is what I usually use because it's more about oxygenation. And for hemodynamic support, there's VA ECMO, which is venous arterial. And probably the trial I want all you guys to look at is called the EOLI trial, EOLIA trial from New England Journal of Medicine in 2018. And what does it show? That patients with severe ARDS refractory to traditional therapy, will they benefit from the early initiation of VV ECMO? That's the big question. Do these patients benefit from the early initiation of VV ECMO? Bottom line point is that VV ECMO does not improve mortality compared to conventional strategies, but overall, VV ECMO still remains a reasonable option in severe refractory ARDS. So if you are running out of ideas, it's never too early to consult cardiothoracic surgery or transfer your patient to a facility that does have ECMO. High frequency jet ventilation, we don't use this in adults anymore. Bottom line point, it may increase mortality. APRV is a form of ventilation on the vent. I'll mention that briefly. Recruitment maneuvers means that you would take this PEEP valve, positive end expiratory pressure. Now, for those of you who are not familiar with PEEP, what is PEEP? Think of it like a valve on the vent that closes as you're breathing at the end of expiration. So it looks like, and when it stops, what's going to happen is that pressure is going to back up. So what's going to happen to the alveoli? They're going to what? Distend. So when the alveoli distend, that helps out with the compliance. It helps out with surface area. But of course, you just can't give as much PEEP as much as you want all the time you want because it has consequences in its own. So when we talk about PEEP, we definitely want to titrate that to what we call the peak and plateau pressures. So a recruit maneuver is kind of like when someone just cranks the PEEP up, like the PEEP of 40 for like 40 seconds. That doesn't have a lot of data for that, and it is very, very risky. But some of you may hear the word recruit maneuver. I don't personally do that. We'll talk about prone positioning, and at last, we'll talk a little bit about paralytics. So let me just give you one slide on each one. So we already spent a lot of time talking about ECMO, and the big thing is you need to be in a center with the appropriate equipment and have expertise to use this. And I would say that you want to save this for people with severe, like COVID-19, but potentially reversible. And that's very hard and very controversial in COVID-19 right now, because who's going to be affected the most? It's the elderly individuals. People are going to be in their 80s, and maybe that wasn't part of their wishes to be on a ventilator and being on ECMO. So this is something that is going to be in discussion about, well, who would be best served by performing ECMO? And one of the many complications of this is going to be bleeding. High frequency jet ventilation. This is a New England Journal of Medicine article in 2013, which said that using this may increase inpatient mortality. As adult critical care doctors, we don't use this. APRV is going to be a mode, and we could have a whole lecture on this, but the big take-home point is that there's not one ventilatory mode that's been shown to improve survival or reduce mortality. This is kind of a, for a 1 second answer, an inverse ratio type ventilation, where you have a very, very long inspiratory time and a very short expiratory time called a drop time. Now, in the inspiratory time, notice how it's squiggly. It's because these patients should not be paralyzed, because on these very long inspiratory times of, oh my God, 4 or 5, 6 seconds, they should be able to pant at these high inspiratory pressures, then a quick drop point, then back up again. So obviously there is a risk of pneumothorax. It's not comfortable, but this is one of the modes that you may see people use, but there's no data to show that any one mode is better. And this mode definitely has its consequences, such as pneumothorax. Paralytics, earlier, I used to say that paralytics had some data about reducing mortality, but a recent article that came out in May 21st, 2019 showed that by giving paralytics, there was really no benefit in using these paralytics. So that mortality data was actually contradicted with this newer article. You should use paralytics when you're having difficulty ventilating the patient, but remember, giving paralytics has consequences too. Neuropathy, myopathy, just to mention 2 of them. And of course, something that is more common than you think is prone position. And prone position, doesn't it decrease mortality? The answer is yes. And this was seen from a classic New England Journal of Medicine study in 2013. But the key thing is that you want to prone these patients, better VQ matching. It doesn't necessarily have to be with a rotoprone machine, but the take-home point is right here. If you're going to prone someone, it has to be at least for 16 hours a day, and it should be done early during that exudative phase of ARDS. You need to do this if you want to get the mortality reduction. So, just kind of the last couple slides, I wanted to mention about ventilator settings. There was no one ventilator setting that has been proven better than another. So when you intubate anyone and you suspect ARDS, choose the settings that you are very comfortable with. It doesn't necessarily have to be a volume assist control ventilator. It could be a pressure assist control ventilator. So a couple things I wanted to mention: you are going to put them on 100% FiO2. You are going to try to lower that FiO2 as quickly as possible. You want to give lower tidal volumes. It's hard to go from normal tidal volumes and cut them right to half. So I would slowly titrate down, maybe start at 12 mLs, then work my way down to 6 mLs. And then I'll use the PEEP to oxygenate. So the take-home message is low tidal volumes to improve survival, PEEP to help oxygenate. And it's that balance between low tidal volumes and PEEP where we get that sweet spot where the alveoli will be the perfect size. And when we talked about the PEEP, I mentioned that we just can't crank the PEEP as high as we want. We titrate it to something called peak and plateau pressures. So what are those? Well, when you're on the ventilator, assist controlled mode, the volume assist control mode, you could check what's called a plateau pressure. So a peak pressure is right here, the peak pressure to get the airflow into the lung. This is called your peak pressure. And what happens is that when you walk into the room and the vent is making all these different noises, like an orchestra, what you want to do is look at the peak pressures. Of course, the patient is hemodynamically unstable and crashing. What do you want to do? Sometimes you just want to disconnect him from the vent and bag him with 100% oxygen and maybe a little PEEP. But if you have some time, you want to check a peak pressure. And so if they have a high peak pressure, what you need to do is perform a end inspiratory pause. An end inspiratory pause is how you check a plateau pressure. So you have a high peak. What happens in the plateau pressure? At the end of inspiration, a valve closes and it measures pressure in the lungs. So right here, here's where you check your plateau pressure. A little air leaks out and it gives you a plateau. Then after you end the plateau pressure, it goes back down to your PEEP. And you are looking for two patterns. If you have a high peak pressure and a low or normal plateau pressure, it's a resistance problem. Mucus plugging, bronchospasm, biting down on the ET tube. Or if you have a high peak and high plateau pressure, then this is something we see in ARDS, pulmonary edema, pneumothorax. If the ET tube, endotracheal tube goes into one of the airways. So you get that high peak and high plateau. This is a compliance problem. And that's why when we talk about PEEP in ARDS, we titrate it to the plateau pressures. And one thing I wanted to mention is finding that sweet spot to help ventilate these patients is still up for debate. And one of the things that we're looking at in pulmonary medicine is something called the driving pressure. And what is the driving pressure? Once again, here's your peak, here's your plateau. You go down the PEEP. This area between the plateau and PEEP is called the driving pressure. And it's really made up of things like your tidal volumes and your compliance. So finding the appropriate driving pressure could be part of finding the appropriate settings on the ventilator to manage patients with ARDS. And as a quick side note, we mentioned that anytime you're on the vent, you want to check an arterial blood gas. And the two things we manipulate is the P-little-a CO2, which was given in the question at the beginning of the presentation, and that was elevated at 50. And there are things that affect the O2 stat, or the P-little-a-O2. And that one was what I believe it was very low, almost 50 or 60 on 100%. So if you want to affect the CO2, you adjust your minute ventilation. So minute ventilation is made up of rate and tidal volume. If you want the CO2 to go down, you increase your minute ventilation. If you want your CO2 to go up, you decrease it. And the right answer to the question, I didn't forget, was PEEP. The patient was only on 5 of PEEP. The PaO2 was very low. The peak and plateau pressures were normal, around 20 to 25. You definitely had room to go up on the PEEP. So the patient already was on 100%. So what you can do is take that PEEP of 5 and go up. And what does PEEP do? At the end of expiration, a valve is going to close, pressure will back up, alveoli are going to what? Distend, make it more compliant, more surface area, more room for oxygenation. That was the correct answer on the board exam before doing a prone position, before doing VV ECMO. Doing simple things first on the ventilator could definitely help your patients come in with ARDS, which is one of the most deadliest things we worry about when we talk about managing patients who have COVID-19. And I put this here briefly just to remind you, there are many types and modes of ventilatory support, and not one mode is going to be shown to improve survival in ARDS. And if you definitely want to hear me give you a full ventilator talk, contact me on my social media, my websites. I would love to give you a full talk about the different ventilator modes. And in summary, I wanted to say a couple things about guidelines of initiating mechanical ventilation. Remember, the primary goals when I decide to put someone on the vent is to provide oxygenation and ventilation, reduce the work of breathing, try to see if the patient could be in synchrony with the vent, which is easier said than done, avoid these high peak and plateau pressures. Remember, you want to lower the FiO2 down as quickly as you can safely. And if you even vaguely suspect ARDS, always give lower tidal volumes. And when we talk about helping out with the oxygenation, use the PEEP, titrate that to our plateau pressure. And things that will be very important once you're on the vent is that to help with the patient being comfortable and pain-free and helping out with ventilator synchrony, you want to choose the appropriate sedation. You want to choose the right analgesic medications. And if necessary, especially with ARDS, thinking about using a paralytic and neuromuscular blocking drug. But as I said earlier, the data about that mortality does no longer exist based upon more recent studies. You would use a paralytic if you needed to help with ventilator synchrony, but you just wouldn't give it empirically based upon it's going to reduce mortality reduction. You know, I have to say that we went over quite a bit today. I hope everyone has learned something about ARDS. It's unfortunate with this pandemic that we will be having patients with COVID-19 that develop ARDS. Many hospitals in California are seeing these patients already. Many of my partners and friends who are also in the critical care field are, managing these patients. So I wish you all the best during these times. Please check out my video about the medications, hydroxychloroquine and azithromycin. I hope everyone has learned from today's lecture, and I wish you all good luck, and I'll see you during our next Beyond the Pearls meeting.